we have the pleasure to have Dr. Dhammika Perrera, who is the Global Medical Director of Mary Stopes International. Mary Stopes International is an organization that really promoted vasectomy all around the world. And we're very pleased to have him telling us about the standards they're establishing on vasectomy. So, Dr. Dhammika, are you there?
Yeah, thanks, Michelle. I've got a few slides, guys, and I think what I'm about to speak about ties into some of the things that we already heard from other speakers today. Um, I'm going to talk about why we have standards and and how standards allow us to reach the scale that we reach year after year. We as an organization, we've been, as Michelle said, providing vasectomy services for many years. And currently we provide roughly between 30 and 40,000 vasectomies every year. And we do that across about 12 countries where we have vasectomy teams. And overall, we have about 300 providers who have been fully trained in vasectomy services. And they range across a number of cadres, going all the way from senior urologists down to clinical officers or physician assistants in some settings. And as Esgar very rightly pointed out, even within our organization, the challenge to scaling vasectomy further up comes from tubal ligations. Just to give you an idea, against the 30 to 40,000 vasectomies we do every year, we do close to 300,000 tubal ligations. Right, and that is because of the demand, and we have tried many a thing to try and generate further demand, and we work with Jonathan's team in a couple of countries. We do our own demand generation, we advocate with ministries, but somehow it's very hard to get men to come forward and volunteer. If you move to the first slide, one of the things that we found out over the years is simplicity is the key. Even to get us to 30,000 a year, we need to hit a level of simplicity that can be standardized and spread across our network of providers. And if you look at the next slide, the second thing we need is affordability. And again, to give you a rough idea, these numbers are from Good Marker, but this just shows the per capita contraceptive expenditure that's required across low and middle income countries. And at this point in time, a tubal ligation costs us only about $30, and that's including the provider's time. And a vasectomy service currently costs us about 40, and that's because we have not managed to, if you go to the next slide, we have not managed as a good job with task sharing with vasectomy as we have done with tubal ligation. If you go to the next slide, that is the third thing we found is critical. So simplicity, affordability, and task sharing. We need to push the the procedure down the hierarchy of clinical cadres to be able to scale it up. And we are in some countries, we are now working with clinical assistants or physician assistants, as they're known, to provide vasectomies. And then those three ingredients are the ones that allow us to reach the scale. If you go to the next slide, I'll talk a little bit about why standardization is critical. Now, we have quite a conventional training cascade. We've got 4 or 5 vasectomy master trainers who then cascade their skills down to clinical trainers who then train the actual providers of the services. The master trainers and the clinical trainers themselves provide the service as well, but the vast majority are provided by the providers who are not part of the training. Now, without standardization, um, if we take this slide to the next, you would see you would very soon end up with different techniques. And these variations in techniques might be in how the skin is prepared. No, if you keep yeah, if you keep that, the variations you see in how the skin is prepared, how antibiotics are used, how pain medication is being given, what kind of post-procedure uh, advice is given to the client, what kind of follow-up is done, do we do sperm seminal fluid analysis or not. So to make sure that across these 30,000 procedures that we have one set of infection prevention practices, one set of pain management practices, and one set of pre and post procedure advice being given to clients. We maintain quite tight standards. We have a 50-page document which we maintain, including a lot of appendices and flowcharts and diagrams as the MSI vasectomy guidelines. And we review and revise the guidelines every 3 years. As with some of the other services that we provide, vasectomy, fortunately or unfortunately, has not been a field that moves a lot. But our guidelines currently include all the variations that we heard today, the clips, the Vicryl, the high pressure local anesthetic gun versus small gauge needles, different antibiotic options, different pain management options. And we maintain what we call a clinical exemption process, where we allow for individual providers' preferences to be practiced, but within reason. So if a provider wants to deviate so far from the guidelines as to practice something that's not on the guidelines, we allow that as well. But then that conversation would happen with a senior person on my team, where we would look at the alternatives that they suggest to practice, and then we either approve them or not. We always try and approve because we want to allow providers to have flexibility and for them to enjoy the procedure and to have it provided in a way that he or she finds acceptable and enjoyable. If you move to the next slide, the other thing that allows us, that standardization allows us, is to learn from incidents. We maintain a very tight system of what we call clinical incident management, where clinical incidents are categorized into red, amber, and green, and that the same applies for vasectomy. So we have a incident guideline which allows providers in the field to categorize a post vasectomy incident into a green, amber, or a red, and the red incidents get reported all the way to my team in London within 1 day. And to answer some of the questions that were raised about such things, with 30,000 procedures, we usually hear about 5 to 10 failures. And usually, as Charles mentioned, these are when a pregnancy occurs. As a standard, we advise 3-month post-procedure seminal fluid analysis, but we do not proactively follow up, because at 30,000, it's very hard for us to proactively follow up. But in the post-procedure, like in the discharge pack, there's a document given to every single client, which gives them a prompt, and there's a stamp, date stamped to say, between this date and that date, you should go and get a seminal fluid analysis done. And we, in most countries, we also give them a list of laboratories that we say, these are the trusted laboratories that we recommend that you go for and get your seminal fluid analysis done. We do hear some failures, but this is about 2 or 3 a year from seminal fluid analysis. But 6 or 7 we usually hear from pregnancies, and some of them go back many years. People who had vasectomies 3, 4, 5 years. We don't hear that much further down. It's usually in that range, 3, 4, 5 years that we hear. If we move to the next slide, please. Yeah, and we review every what we call a red incident, which is usually a severe infection, Fournier's disease kind of situation, or a infection that required hospitalization and intravenous antibiotics, or even if it was like where a second round of antibiotics needed to be given. And we share the learnings from these incidents across the partnership. So when we have an incident in, let's say, Papua New Guinea, within a 3-month period, that incident and the learnings from it gets disseminated across the 35 countries where we operate. Next slide, please. Yeah, next one. And then standards also allow us to train people according to a given format. If we go to the next slide, this sort of shows our training cascade. So we organize trainings and we fly in the master trainers to do training of trainers. And we include not only MSI providers in these trainers of trainings wherever we can. We also invite the Ministry of Health and other organizations to send people they want to be trained as clinical trainers, so that we maximize each visit that's done by our master trainers, and then they cascade down. And the training packages we used are designed based on the guidelines. So when the guidelines are revised, we revise the training packages. If the guidelines, if something new gets added to the guideline, we always look at whether that should be added to the trainings as well or not. Next slide, please. Yeah, and that's it. I'm more than happy to take any questions. I was trying to summarize a lot into 5-6 minutes. I don't know if I went over time, but thank you very much.
Thank you very much, Dr. Perrera. That's very amazing what you are doing all around the world. We have problems standardizing our practice within 3 or 4 practitioners, and you're doing that on hundreds of them. Congratulations. And actually, it would be really nice if you could share all the documents you're producing with the group. This would be, and I'm very sure that members from the group would give some input if you ever want. We have this opportunity to discuss all our clinical and logistical topics. So please be part of the group.
Absolutely. Actually, we are about to start the revision of our guidelines, the next iteration. So if there are volunteers, as I mentioned, it's 57 pages with appendices, but that's with very conservative formatting. So it's actually not that much of a reading. If anybody would be willing to have a look and give some comments, suggestions, we would be very happy. I would be more than happy to share it with you and then include feedback in the next version.
I would suggest that you just send a message to the network, and I'm pretty sure you're going to have tons of volunteers. Thank you so much. Thank you so much.
Absolutely. It's a pleasure.
Is there any question, Deidre, from the participants?
Michelle, on the chat,
Okay.
Dr. Chris Tanazi sent in a good thing. I wish he could have raised his hand so we could see Chris, and he's certainly welcome to do so.
It's a very good question, Doug. Yeah, so the question is, incident reporting system is amazing, but it seems like it could be shaming for the practitioner. Is there a way to avoid that? And the answer is yes. We maintain what we call a no blame culture. And we maintain the no blame culture by talking about it. And we do this incident management trainings, which focuses not so much on the incident types themselves, but on the no blame culture. And we preserve that no blame culture by doing. How we manage that is whenever somebody reports an incident, even if it's a critical incident that gets reported all the way up to me, the first response they get is a thank you. And we have standard responses, email templates, where every person who reports an incident automatically gets a thank you email for reporting. And then we have a clinical panel of 12 people who are the incident review panel, and their communications with the team involved in the incident as they study it and get to the bottom of it and do what we call a root cause analysis is always
Siempre hacemos análisis
an
del grupo.
attitude of gratitude.
Es una actitud de gratitud
We
que
never
ofrecemos.
take punitive actions
Nunca no hay acciones punitivas por reportar.
If we see incident
Vemos
trends,
incidentes,
we see spikes in
si
certain
vemos
cases,
incidentes o
then we do what we
ya
call
vemos,
an audit visit or an
hacemos un
incident
audit
visit to look
donde
into the cause,
visitamos el lugar para
but we
ver por qué
never talk about
hay
the
estos
incident.
errores continuos.
And it works. Just to give an example, we get about 1,200 to 1,300 critical incidents reported to us,
Hay
not just from vasectomies, but from all our services every year. And that includes about 18, 20 fatalities from critical infections. But just to put things in perspective, we see about 1 million procedures a month. So at that rate, we see that many incidents, but they keep reporting. And we have benchmarks for different services about the percentage of incidents we expect to see. And when we see those benchmarks challenged, we look into that. We also look into that when we see terribly low incident rates, when things look just too good to be true. So yeah, thanks.
That's very nice. Thank you very much.
Yeah, Dhammika, is there any room for individual variation? Look what we've heard today. Some doctors like plain for fascial interposition, some like Vicryl, some like hemoclips. Suppose the standards are for, let's say, Vicryl, and some doctor says, I like the feel of plain. I've been doing these for a long time. Is there any room for that?
Yes, for all our procedures, including vasectomy, we maintain, as I mentioned briefly, what we call a clinical exemption process, where providers can apply to deviate from the standard. And then senior guys in my team, they review the application for deviation, which is and we have a standard template for it, which is a 1.5 A4 sheet little thing where they only have to type in a little bit of blurb, rationalizing why they want to deviate. And then we do a quick search of the evidence. And then usually we give a go ahead. We do that because we have what you call an external clinical audit system, where people from one country go to audit the practices of another country, so that we maintain a database of all the exemptions that we have approved, so that when a auditor is going to do an audit of a country, we can let them know the deviation from standards they should expect to see in that particular country.
Thank you.